Welcome back to another episode of Here for Healing. And today on the podcast, we have Dr. Sarah Carpenter, who is the proud owner and pediatric dentist at Homegrown Pediatric Dentistry in Spicewood, Texas. She brings world-class training and a true passion for children's oral health, and is also a mom to 3 beautiful children. She has advanced training in airway-focused dentistry, which is something we're going to dive into pretty deep today, frenectomies and tongue and lip ties, myofunctional therapy, and whole body health connections. She's also our personal dentist for my children. So welcome to the podcast, Dr. Sarah. I'm so glad you're here.
Thank you. Thank you for having me. I'm excited to be here.
It's your first ever podcast.
First podcast, yes.
So exciting. So, these are the exact questions that I actually came into your office asking. Maybe a month or two ago, I was doing some research on social media and there was just so much coming up about, airway dentistry specifically for our children. And so I came into your office, I made an appointment just to have that discussion to see if it was something that the boys needed. And I was like, this would be amazing to get this information out to parents. So I appreciate you doing the scary thing and getting on a podcast for the first time.
Of course. Yes, it is really interesting. Once you start learning all about airway and how it's so related to your mouth and, starting at a young age to correct some of the issues. A lot of people will just kind of brush it off and say, oh, they'll grow out of it. But then we see so many adults with sleep apnea and anxiety and depression, and that can all be corrected when we start at a younger age, and so that our children don't have to grow up with those health issues. Mm-hmm.
Yeah. So the value of prevention is so powerful. Mm-hmm. And so even before we get into the specifics of the airway for children, when I was looking for a dentist, I go to a biological dentist for my own self. I go to Healthy Smiles for Life in Marble Falls, and I wanted the same care for my children. And so I found you, who is a pediatric biological dentist. So off the bat, tell me a little bit about why your practice is different and why you set up your practice that way and not a just, conventional dentist.
Right. Number one thing you said primary was that prevention is key. And so that's my main goal at my office, which is why we named it Homegrown. We talk a lot about healthy foods, healthy life choices. It's not just don't eat candy. There's a big range of what causes cavities. And if we can prevent that and teach our kids at a younger age the choices that they can make throughout their day that can help improve not just your mouth health, but also your body health. And so that's my primary goal, is to improve the child's whole body health, not just because your oral health is correlated. Your oral microbiome is correlated to your gut microbiome. And so we want to have, the good bacteria and less of the bad bacteria. So part of that is teaching. A lot of it at my office, that's our primary focus, is teaching kids and parents, but sometimes the kids need to hear it from somebody other than their parents.
Yeah.
And so that's our primary goal. But going along with that, it's I get to choose, as the owner, I get to choose what products I purchase, which products I'm using for fillings and all of, even when it comes down to the type of toothpaste that we're offering. And so we try to choose products that are less harmful chemicals and safer products for our children that they're putting into their bodies. And so,
what I'm curious, what are some of those? What are some of the swaps that you've made in your office?
Yeah.
Ingredients or materials that you're using instead of more conventional ones.
Right. So, I would say most offices nowadays don't use mercury fillings. So that's kind of like an obvious one.
Okay.
But, most people don't use that anymore. The amalgam silver fillings, but as far as like the white composite material, if you needed a white filling, some products will contain BPA, but we just choose the product that doesn't have BPA. Same with sealants. If you needed a sealant, we choose the product that doesn't have BPA. Fluoride is a big hot topic right now. So there's an alternative to fluoride that helps remineralize your teeth. It's called hydroxyapatite. And It's what your tooth structure is made of. So when your body forms a tooth, it uses hydroxyapatite to make the enamel of your tooth. So it's already in your body. It's kind of like calcium, or it's a mineral that's already found in your body. And so it's just putting the minerals back into your teeth that were already supposed to be there. So whereas fluoride is not naturally found in your body, so we offer the hydroxyapatite as an alternative. We also offer iodine treatment, like intraoral iodine treatment, to help decrease. We talked a little bit about your microbiome. And so that's one of the factors that cause cavities for kids, is just what type of bacteria that you have naturally found in your mouth. And so obviously we want to promote the good bacteria and decrease the bad bacteria. So the iodine treatment kind of helps decrease that bad bacteria. If children are more prone to cavities, then we offer that as an in-office treatment. And also we have, like toothpaste and a varnish that we could put on their teeth that has more like oral probiotics in it, to try to help promote the good oral microbiome.
Mm-hmm. And when it comes to the teaching, mentioning like teaching the children, teaching the parents, that makes so much sense. That seems like common sense, to change their habits so that the very problems that they're coming in with, they actually get to make, root cause changes, as opposed to just coming in with the same issue over and over. What are some of the common issues that people, are cavities the biggest one, or for children, what are they coming in with?
I would say cavities is a very high, I don't know exactly the percentage, but more than half kids in the United States get cavities under age 12. So it's one of the highest diseases. It is a dental disease is the technical term for it. So it's one of the most common preventable diseases. So if we can prevent it, that's the goal. And so honestly, there's a wide range of what causes cavities. So part of it is brushing and flossing. Like if you're just leaving plaque and food on your teeth, it's going to end up causing demineralization, which is the minerals are getting taken out of your tooth from the plaque just sitting there. And that will eventually form a hole in your tooth. And that's what a cavity is. So part of it is brushing and flossing, the consistency, and whether you're doing a thorough job. Most people know that already. Part of it is their diet. So kids just snack so frequently throughout the day. I have kids. I know how often they ask for a snack. But it's just the types of snacks that you're choosing. So if you wake up and have cereal for breakfast, and then an hour goes by and they eat a granola bar, and then an hour goes by and they have a cup of juice, and an hour goes by and then it's lunchtime and they have, like processed food, like a chicken nugget or something that's not a whole food. If it's just like consistently throughout the day having these processed carbohydrates, so like goldfish, fruit snacks, and gummy vitamins cause a lot of cavities for kids. Juices, anything that's not like fruit, vegetables, cheese, nuts, yogurt, meat, like a whole food can cause cavities. So, and it's more like the consistency throughout the day that they're having it. So I'm not going to say never let your kid have a granola bar, or my kids eat that, but if just be intentional about it. And if they are at home and you're able to give a whole food option as a snack, and then save the packaged snacks for when you're out and about and you have to throw something in your purse. So that's the other factor, is just the frequent snacking. The other factor I would say is just your oral microbiome. And so that's what's hard to control. It's actually usually passed down from parents at the infancy stage. So like if you as the parent have a lot of cavities, then you may have more of like the bad bacteria that cause cavities. And then when you share spoons or share cups with infancy stage, that's when their oral microbiome starts developing. And so then that can get passed on generationally. So a lot of people think it's genetic. It's usually not genetic necessarily like in your genes, but it is passed down through parents. And then, so yeah, it's brushing, flossing, snacks, and your oral microbiome. So that's why we try to, change your oral microbiome, which is a challenge to do, but just takes consistency and time. And then the last factor is mouth breathing. So mouth breathing changes the pH of your mouth and makes you more susceptible to cavities. So at our office, we really try to focus on all of those factors because it's really complex. It's not just like you eat too much candy, that's why you got cavities. Obviously, we want to discourage candy, but that's not the main contributor, I would say, to cavities.
Right. So with the mouth breathing, what is at the root cause of why that's happening? Are there children who are they're just breathing with their mouths shut? Like, I feel like I watch Cruz. When I became aware of this, I'd watch him at night and like his mouth was open. Why is that happening? Let me ask that.
Oh, that's a big question. Okay. Mouth breathing is usually because a child feels while they're sleeping, they feel like they're not getting enough oxygen by breathing through their nose. And so they'll grind their teeth because they're trying to they're trying to move their jaw forward to pull their tongue forward to open up their airway more. Or if they still feel like they're not getting enough oxygen, then they'll open their mouth and mouth breathe to get more oxygen. But our bodies are not designed for mouth breathing. Our bodies are designed to do nasal breathing. And so nasal breathing is calming and relaxing for your body. Mouth breathing, you're really only supposed to mouth breathe if you're in fight or flight mode. And so it's confusing for your body when you're resting in your bed, but your body is releasing cortisol, stress hormones from mouth breathing, and it makes you not be able to stay in a deep sleep as well. A lot of times also when you get into REM sleep, your body really relaxes. And if you already have a narrow airway and then your body relaxes and the muscles relax, it closes your airway more. And so it'll take you out of REM sleep, so you're not getting that deep restorative sleep. So it makes you more tired throughout the day. It makes it harder for the kids to focus in school, can lead to ADHD and anxiety and depression in teenagers more if it's not corrected, like at an earlier age.
And so before we started the podcast, you said that one of the reasons, we were just chatting a little bit, that this narrow airway is happening, or one of the contributing factors could be like having a passy for too long. What is it? What are the other ways it could happen?
Yeah. So part of it is just our culture, and I'll kind of take you back to square one. So as an infant, nursing your child, breastfeeding is going to help develop their jaw the most appropriate way. So not everybody is able to breastfeed. And so bottle feeding can change the shape of your jaw to become more narrow. The baby's mouth don't have to work so hard to get the milk with the bottle. Whereas breastfeeding, the baby has to do some work there. And so it helps strengthen their jaw and facial muscles. So let's say you're able to nurse your baby for a whole year. And then once they start eating solids, they're not really eating solids. They're eating like pureed soft food. So then they stop using their jaws and developing their muscles. So the more ideal way, in an ideal world, you would nurse your baby, breastfeed your baby, and then when you switch to solids, it would be more baby-led weaning, where the baby's picking up the food and actually chewing and using their jaw.
To strengthen, yeah, okay.
So our culture kind of just purees everything or just goes to bottle feeding, which obviously you're going to have to feed your baby. Like if you're not able to breastfeed, but it's not the end of the world. It's correctable, but just that's one factor. Part of it is genetic. Part of it is just your genetic makeup of how your jaw is structured. If you're a very thin, petite human, then your jaw is probably also going to be more thin and narrow. But the part that we can control is breastfeeding at an early age, switching to baby-led weaning. So we have like a course at our office for baby-led weaning to try to help promote that, because it can be a little overwhelming if you're a first-time mom and you want to start doing baby-led weaning. It's a little, you're like, is my baby gonna choke? So we have a course. We have nutritional counseling at our office that helps train the parents how to do that. Okay, so that's like infancy.
Okay.
Then if they're thumb sucking or pacifier use for an extended period of time, that can also change the shape of your jaw and create it to be more narrow and have a high arch. So the roof of your mouth is really the bottom of your nasal cavity. So if it's too high, it can restrict airflow through your nose and then cause kids to do more mouth breathing as they grow. So that's another factor. And we're seeing, a lot of more extended pacifier and thumb sucking, where it's like usually we would recommend to stop thumb sucking or pacifier by age 2. But if it continues past that, it can kind of change the development of your face. And then, so let me go back here. So there's breastfeeding, baby-led weaning, the pacifier. The other factor is we're seeing a lot more tongue ties. And if your tongue is anchored down to the floor of your mouth, if it doesn't have proper mobility and movement, it can make it more challenging for your tongue to be in the proper position. And so ideally we'd like our tongue when we're resting. So whenever we're not eating or speaking, your tongue should be as if you're going to say the letter N, and that's where your tongue should be placed.
Okay.
So if your tongue is in that position whenever you're not, so especially during sleeping, but whenever you're not eating or speaking, your tongue would be in that position, and your bones grow under pressure. So if your tongue is putting pressure in the proper position, then it will cause your jaw to grow wider and create more space. So more space for your permanent teeth. So that would be less need for orthodontic treatment as they get older. And also opening the palate will also open the airway.
This is so fascinating.
Yeah, it's so interesting. Once I started learning about it, I was like, everyone needs to know. Every kid needs this, because it's not every kid. A lot of children need it.
Well, that was my question. How many people are coming into your office that you feel genuinely need to work on their airway and their palate?
So when I see like crowding in baby teeth, the baby teeth are really crowded, that's kind of a red flag for me. If I see like the teeth are very worn down because the child's grinding, that's a red flag. You can see kind of like dark circles under their eyes. And so that just may mean they're not getting restful sleep, and it's changing the shape of their face. So their eyes are kind of sunken in more instead of, so there's signs that I look for visibly, but then we also talk to the parents, like, how are they sleeping? Are they getting good rest? Are they grumpy during the day? Are they tired throughout the day? And so we have like a little quiz that the parents fill out to kind of gauge if the child's having symptoms from a narrow airway.
Do you find that it's more parents coming to you and saying like, hey, can you check their airway, their palate? Or do you find it's more you are doing maybe like a routine cleaning and you notice it?
I would say most of the time it's me noticing it, but it is becoming more prevalent, and social media is really promoting this. Yeah. So it's becoming more people are becoming aware of it. So we are having patients coming in specifically just for an airway assessment. But some people have never even heard of myofunctional therapy. And so when I bring this to their attention, they're like, interesting. I never knew that my kid grinding their teeth at night, or, my child is still wetting the bed, or my child is having night terrors, or things like that are correlated to their mouth. Right. They're not something that you would commonly think of as being related.
Yeah. And that's just really the whole theme of biological dentistry, is looking at how the mouth is connected to the rest of the body, and it's
Exactly.
not just isolated. So what age do you start doing something about it? Because my boys are 3 and 7, and I wanted to check with you about it. What's the typical age that you start giving them either practices or a palate expander or something like that?
Yeah. So I would say if a child has any issues like this under age 3, there's not a lot that I can do at that moment. And I mean, I'll check for tongue ties. But aside from that, there is a product that's called a myomunchie. It's something that they chew on that just kind of helps stimulate the jaw muscles to help proper jaw development. But most 2-year-olds wouldn't cooperate. I have a 3-year-old. Like even he, I don't know if he would be able to cooperate for the myofunctional therapy exercises. It's a lot of following instruction. There's a brain to tongue connection that happens around 3, but not every 3-year-old is ready to place their tongue in proper positions and really understand what they're doing there. So
Right.
I would say like 3.5 and older, we start with myofunctional therapy. And those are just exercises that we teach the parent and the child that they would do at home to try to help strengthen all those muscles, and then also teach them to put their tongue in the proper position and to do more nasal breathing. And then palate expansion. So there's a few different types of palatal expanders for kids that have severely narrow arches and a lot of the symptoms that we're looking at, and we want to try to alleviate some of that. We do have an expander that it's a metal appliance that gets glued into the back molars, and you leave it gradually helps the jaw grow. But you have to have a cooperative kid for that. So we kind of gauge it based off of the patient's cooperation levels. But that would be if a child doesn't have any permanent teeth yet. And that's only for really severe crowding. Once a child starts getting permanent teeth, so age 6, 7, 8, we're noticing some crowding where there's not going to be enough space for all the permanent teeth to come in. And we're trying to open up that palate and open up their airway. Then there's different kinds of expanders. So we do at our office, we do Invisalign expander. So that is one option, but it is removable. And so we have to also have a compliant child who will follow the rules and keep it in. And then there's another type of expander that it similarly gets glued into the back molars, but then the parents turn a key each night, and it helps the jaw grow faster. We don't do that one at our office. That's would be like at an orthodontist specifically. So but there's a lot of great orthodontists in the area. But so there's multiple options, but it just kind of depends on the child's age, cooperation levels, and also how severe their crowding is. And not everybody needs an expander. Sometimes just correcting with the myofunctional therapy is helpful. And some kids are blessed where they just have perfect spacing and they don't need anything.
Let's pray for that.
Yes. Yeah.
Well, because Cruz will be 7 in February, and he didn't have any of the symptoms. But I did notice that he was mouth breathing at night. So in his case, that was where you and I talked about just starting with the myofunctional practices.
Exactly.
Yeah. And then just kind of, I had that key expander. I remember that.
It's hard to forget.
It's true. What about doing this for adults? Like, I have a friend who has been doing her airway expansion, and I mean, it's completely changed the shape of her face and how she can breathe. What's the process for adults to do it? Same? Is it a palate? Is it the key?
It's yes. So they have to actually get little tiny micro implants in their palate. And then you have to turn the key.
Okay.
And orthodontists do that. I do not place micro implants in adults.
Okay, got it. And is it the same symptoms as what kids would be experiencing? Like, why would an adult be looking for this? Would it be more aesthetic?
I I would hope not, just for aesthetics.
Okay.
It's mainly because honestly, orthodontics kind of changed their mindset. And so, like when I was growing up, a lot of kids didn't get expanders. They would just wait until all the permanent teeth came in. And if there wasn't enough space, then they would just pull teeth out to make space. So if somebody needs an expander as an adult, it's most likely airway related because they're having sleep apnea and, having a really hard time breathing.
Okay. So for parents who are listening to this at home and they're wanting to do something to, alleviate any further problems down the road, the myofunctional practices, because I remember asking you, like, do you mouth tape the kids? And you said no, right?
So I don't recommend mouth taping kids overnight because kids will get congested with sicknesses so rapidly. And if they're not able to take the mouth tape off on their own, I wouldn't, that would be a worst case scenario.
Of course, yeah.
So some part of the myofunctional therapy will recommend doing some mouth taping during the day, like when they're reading or coloring or watching TV or driving in the car, at a time where they're not going to be eating or speaking, and starting slow, like
Which
starting
is not very often.
Exactly. It's like, you only got 5 minutes. So that's an option, but we do have, the tooth pillow appliance, which is a mouthpiece that the kids can wear that promotes their tongue to go in the proper position and encourages nasal breathing for the nighttime. But usually my recommendation with that is try the myofunctional therapy first. And if they can learn to do it on their own without an appliance, that would be better. The appliances, there's an adjustment period where, the first night they wear it, they're not going to love it in their mouth. So it takes some getting used to. So, and it's also kind of expensive. So I would try the myofunctional therapy first and see if they really need the appliance, to try to decrease the mouth breathing at nighttime.
Do you have any pre-recorded videos or anything like that show what these exercises are, or it's more like you have to give them to a specific child, so they need to come into the office?
I don't have them pre-recorded. Sometimes if a parent is like, I forget what that one is, can you remind me? I'll send them a quick video of myself doing it, but I don't have them pre-recorded, because we do customize the exercises for each child. And also we like to do it in office. We give you like a little bag of tools to use for some of those exercises. And we show them how to use it. We take measurements of the child, and so we can track their progress. And we do see a lot of kids that have really great progress with it.
Awesome.
So it's really cool to see that. And also the parents with the myofunctional, when they sign up for the myofunctional therapy exercises, we encourage the parents to do it with the kid, because the kid's not just going to do it on their own. Like, they kind of need guidance. And so we have parents come in saying, like, I have better sleep, I'm not snoring, or I'm not grinding my teeth anymore, because the parents are doing it with their kid.
Yeah.
So that's kind of cool to see
That's
too.
a great side benefit.
Yeah.
And so how popular are pediatric biological dentists around the US? How would someone find one if they're not able to come see you?
Good question. I would say it's becoming more popular.
Yeah.
I think that, which is great. I love that people are becoming more, because this is not stuff that they teach you in dental school necessarily.
Right.
So you have to do a lot of the learning on your own and take the continuing education classes, which are becoming more popular. You see the repercussions of having a tongue tie and then having it not be corrected. And so those are becoming a lot more popular. Correcting tongue ties is becoming more popular. But as far as learning how to be a biological pediatric dentist. I mean, I can think of 3 in our general area, which I would say is more than there were 10 years ago, you know? So
maybe it needs to be like a word of mouth thing. Like ask your healthy friends.
Yes. I don't know how you find them. Google. I don't know.
Yeah. So ask your friends who are into holistic health and nutrition and where they're bringing their kids. And this is why I wanted you on the podcast, because I'm like, this is fascinating. I need to learn more about this. And I was so mindful of where I brought my children to get their dental work done. So I'm super grateful that we're able to share this information out there. With the frenectomies and like the tongue and lip tie, all 3 of my children had to have the revision done. With my first, it was like 2 weeks of just bleeding nipples and pain and suffering and nipple shields. And he was my first. I didn't know, right? And so we waited about 2 weeks to get the revision done, and it did help, but there was a lot of like repair to do for my nipples after that time. And then with Cash, when we found out we had to do it, I think we did it in like 5 days. And with Kai, who's now 3 months, I was like, he was born, he latched, my nipples started bleeding. I'm like, okay, how soon can we do this? And it was a Friday, and the office opened on Monday. So I brought him on Monday. It seems like it's very common, like all 3 of my children having this. Do you find that it is true that the earlier they do it, the better? And here's the reason, the base of my question is because I have a mom friend who was told that the baby needs this tongue tie, but she's not in pain the way that I was. Like I couldn't breastfeed until I got it revised.
Right.
What would you tell her? Is it better to do it sooner or kind of wait and watch in that case?
I would say there is an overdiagnosis of lip and tongue ties.
Okay.
And everybody has a lip and a tongue attachment.
Right.
How restricted is it? Like, are you able to move your tongue properly? Is the baby able to move their tongue in like a wave-like formation to swallow appropriately? Or is their tongue anchored down to the floor of their mouth and they can't do it? So you can have like a thick, short attachment that's really preventing the movement of the tongue. And in that scenario, I would say you probably need the tongue tie corrected. If it's stretchy and the child's still able to move it, the amount of tongue tie, if they're able to move it, the tongue tie correction only helps facilitate better movement. But if they're already able to move their tongue properly, there's not going to be a benefit.
Stretches or
yes, okay. Right. There wouldn't really be a benefit to it. So if the child is latching, gaining weight, not having symptoms, the mom's not having symptoms, I wouldn't put a child through a unnecessary procedure. It is becoming more prevalent with the lip and the tongue ties. And one theory, I don't know the accuracy of this, but it makes sense to me, is that because I had 3 kids and one of them needed a lip and tongue tie correction. And that's really what facilitated my dive into, well, I'll tell you, my first child needed it, but I didn't know about it.
Okay.
And then when, again, kind of like your story.
Yeah.
The second baby, I was like, I know this baby has a lip and tongue tie. I just drove them straight to my office from the hospital. I was like, don't even go home. Just go straight to the office. I'm fixing that on the way home.
Okay.
My third kid did not have that. But my third kid, somebody at the hospital told me that he did have a lip and a tongue tie.
Okay.
And I was like, no, he doesn't.
You're like, I know.
Yeah. So it's...
Yeah. That's helpful though.
It's hard to say for sure. There's a lot to look at too.
Yeah.
Because a lot of babies have a lot of tension and tightness and like torticollis and just in trauma from birth. And so that tension can correlate to difficulty with nursing. So it's not necessarily always a tongue tie. But it is becoming a little bit more prevalent. A lot of babies I examine a lot of babies to see if they have a lip or a tongue tie. And I would say probably half of them actually need the treatment and half of them don't. And one of the theories that I was going to mention is that as pregnant mothers were kind of recommended to take folic acid to try to prevent spina bifida in our prenatal vitamins, because spina bifida is an opening. The spinal cord didn't fuse all the way. And so the folic acid helps fuse the center midline, but in doing so, it may cause more lip and tongue ties.
Interesting.
Which, I mean, lip and tongue tie is not as severe as spina bifida. You don't want to have spina bifida.
Yeah, right.
But it's hard to.
It's interesting.
It's hard, yeah. But that may be one reason why we're seeing it more often.
So, I mean, we chatted about a lot between like the nutrition and the lifestyle and the strengthening of the jaw, which is super fascinating. Brushing, flossing, using better alternatives like hydroxyapatite. And that's the toothpaste. Do you recommend a hydroxyapatite toothpaste too? Okay. Is there anything that we didn't touch on that just like a mom, parents, mom, dad, we want to do the best for our kids? Anything else that we can be aware of when it comes to our children's oral health, just to make sure that they're set up for the best long-term outcomes of their oral health?
Yeah. So, I mean, a lot of dentists focus heavily on cavities. Obviously, nobody wants cavity, but I would say cavities are common and like not as important as your airway. Like you need oxygen, you need to breathe. And so in order for our bodies to breathe appropriately at night so that our bodies get enough rest, so that our bodies can grow appropriately, so that we can learn the most during our school day. And so that, I tell kids, I'm like, oh, if we can teach your tongue to go in the right position, then you'll sleep better, you'll grow taller, your muscles will get bigger, your brain will get smarter. So it's a lot of parents don't really know how their child sleeps. So I would just encourage you to like go look at your child while they're sleeping, and if their mouth is open, take a look again the next night. And if their mouth is open, then maybe, if they're consistently mouth breathing, that can turn into long-term issues. Same with grinding. If you notice your child grinding their teeth, it's not always airway related, but it usually is. And so I would just have it talk to your dentist about it and see if there's something that we can do to help alleviate that.
If someone goes to a conventional dentist and asks about this, will they know about it or like have studied it at all? Or are they just going to be like, yeah, I can't help you there?
Some, like the old school philosophy was that grinding is normal for kids. And I would say it's not normal, but it's common. And so just because it's common doesn't mean that we shouldn't try to prevent that from happening. But there are other factors with grinding. Like sometimes it's associated with parasites. Sometimes it's associated with new teeth growing in, and just feeling the pressure of new teeth causes kids to grind their teeth. So if it's like a consistent chronic problem, then it's maybe more airway related.
Awesome. Well, I learned a lot. I know when I left the office, the recommendation was to do the myofunctional practices, and now I'm actually going to make the appointment to do that. So, this was incredibly helpful, and I'm just grateful that we'll be able to get this into more parents' hands so that they can get to the root cause of what's going on with their children and hopefully alleviate any further suffering down the road.
Amazing. Thank you.
Thank you so much for being on the podcast. You did great for your